So actually many people think that IABP has no role, but it has an immense role. I will highlight the cases what we have done. It's the most commonly used. Even in US, 70% of the patients, they use IABP, not this one. The main important thing is because there is no supportive data. See, improves the physiological parameters significantly. More important, improves the cardiac output, coronary perfusion, reduce the myocardial work, and decrease the pulmonary capillary wedge pressure, LVDP, improvement in multi-organ dysfunction. The only disadvantage, not only with the IABP, even ECMO, IABP, until recently, even Impella, they don't have any supportive evidence in any randomized trials in terms of reduction in the death rate. So that's the one. So it was started first time in 1967. So 67, even now it is continuing. That means there must be a very good supportive evidence, otherwise people will not use it. So we use commonly like a IABP, Impella in India. 3 are available, widely used. Impella and VECMO. So one of the advantages is very simple. The cardiac output improves only 0.5 to 1, and access site, the sheath size is very small compared to ECMO and Impella. Invariably, the access complications are lower compared to IABP and ECMO. The readily available, every center is going to have the, and bedside insertions, simply you can do the TE and decide where exactly. You can bedside procedure and no anticoagulation. Only thing you should know the contraindication, like a peripheral vascular disease, itoconazism, these type of. So if you see the 3 major randomized trials, IABP shock 2 trial, no mortality benefit, ACLR shock based on the ECMO, no mortality benefit, whereas a danger shock trial, the first time one randomized trial has shown 12.7% mortality reduction. So because these two, they don't have a randomized data to support, the guidelines have recommended class 3. Because the Impella has only one randomized, they promoted from class 3 to class 2A. If they are going to have one more double randomized trial, it will move to class 1. So to enter into the class 1, at least 2 randomized trials should be there. That is the rationale of. So if you see the latest American College of Guidelines, see in 2013, IAB was 2A. Then in 2025, moved to class 3. Whereas IAB, the Impella, it moved to 2A. So if you see the inclusion criteria of the Impella, they have chosen the lactic acid levels, lactate levels less than 2.5, and out of cardiac arrest patients are lower in number, and they have chosen the inclusion criteria is very, very strict. So if you apply the same criteria in the present scenario, IABP and ECMO, are they going to improve? That is debatable. So, and only thing, there is no supportive data. If you see the IABP trials, the TACTIS trial, ARIAS trial, IABP shock and IABP 2, none of the trial have not shown any survival benefit. And they also compared tandem heart versus IABP, and that is also pooled data for Impella and IABP. None of the trial, even meta-analysis, did not show any mortality benefit versus IABP. But they also showed increased complication rate, MACE rate, particularly access vessel bleedings are more with tandem heart, Impella, as well as the ECMO. This is a standard IABP shock 2 trial, 600 patients, the classic shock, cardiogenic shock, they included. And this was published in 2012, and there is no mortality benefit. So yeah, they also did the 6-year follow-up. In the 6-year follow-up also, there is no mortality benefit. IABP group versus non-IABP group. That is the reason it moved to class 3. Some of the large observational studies also failed to prove survival benefit. Not with the Impella versus IABP. IABP did not show any survival benefit. And IABP was compared head-to-head against percutaneous MCS devices such as tandem heart, Impella, and Impella CP, but there is no survival benefit. Only, again, the complication rate is much more in the advanced supportive devices. The meta-analysis, they also compared IABP versus Impella, tandem heart. There is no reduction in the 30 days mortality. And this ALTAC shock trial from Italy, they have stopped the trial because there is no conclusion, there is no supportive, no favorable results. That's the reason they stopped prematurely. If you see the pooled analysis, the LVAD, BIVAD, the tandem heart, Impella, if you see the Impella, the bleeding rate is low, infection low, and stroke rate is very low compared to any other device. I'll show one case. This is a 48-year-old male, diabetic and hypertensive. He was suffering from recurrent dyspnea, refractory failure. When he came to us, then you see the patient is having a double CTO, L6 total, RCA totally excluded, LED totally excluded, and I think it's can you play this one? Oh my God. So both, is it play? Actually, oh yeah. So the double CTO, he was surviving only on L6. L6 was 90% lesion. Then we said we can go with Impella refractory. Initially we treated with the guideline direct congestive therapy, and then we again L6, LM to L6 was stented, OM was dilated, and subsequently you see the patient recovered remarkably. But on 6th day, after removing the Impella, second day we have removed the Impella, 6 days he was fine. But after that, patient developed gradually a rise in lactate levels. Lactate levels, again pressure is dropping. Then what happens? The patient again, cardiac output, because of the falling cardiac output, then we were forced to put IABP. IABP started on 6th day, again lactates improved, liver function improved, everything improved. Again, 10th day, a patient developed a right side thrombosis, that Impella, that IABP removed, site was removed, other side extended one more IABP, and patient almost, he was an IABP after Impella for 15 days and recovered very well. On almost he was there for 25 days and he almost 2 years follow-up. This is a 55-year-old male, came with extensive anterior MI, triple vessel disease. Here it's not playing, triple vessel disease. So you can see the patient came with an anterior MI. Initially we did the LED stenting, but L6 is very tight and right corner is very tight. Then what we, on 6th day, patient suddenly developed hypotension, VTBF, cardiac arrest, post-procedure, then lactates was rising, pressures were low, then forced to put IABP. Then we put the IABP, shifted the patient to the cath lab, then immediately we did the L6 stenting as well as the right coronary stenting and improved remarkably. Then this is how you have to see. This is the, you can see the procedure, L6 and RCA stented, recurrent VTBF. And when you see the STEMI patients, always classification is very important. In which stage? Is it in A to E, in which stage? And if it is in B and C, still IABP, you can go as per the SKY recommendations. Then if it is C advanced stage, D and E, don't go with IABP, or if at all using IABP, ECMO with IABP, if low cost, otherwise you go with Impella. If a class D advanced and E, even Impella will not work. You have to go with the Impella 5.5 or you have to go with this one. Always see the right ventricular dysfunction. If the right ventricular dysfunction is there, Impella is not, the IABP is not going to work. If the left ventricular end-diastolic pressure is high, check the PAPI. Is PAPI is indicative of right ventricular dysfunction. CPO, is it less than 0.6, that indicates LV dysfunction. CPO less, PAPI is definitely indicative of right ventricular dysfunction. They need a right, like ECMO type device. Suppose if there is a PAPI is normal, a CPO is low, LV support device. In early stage, IABP. Follow the lactate levels, follow the pressures. If it is patient may improve. If they don't improve, escalate to Impella. That's the strategy you have to adapt. That would be very cost effective. So sometimes what happens, one device may not provide the adequate cardiac support. In such cases, always see his cardiac output is maintained, cardiac index is maintained or not, patient lactates are falling or not, systemic perfusion is fine or not, urinary output is fine or not, ischemic features are less, and that you observe. If that is there, then if that is not there, if ECMO is there, you add IABP to decrease the pressure and to reduce the afterload further, or combination of impeller plus this one, or increase the impeller 3 is there, the impeller CP is there, escalates to 5.5. That's how you have to adapt the strategy. So why the previous studies failed? If you see the latest observational data, so we have learned many things through the latest data. Identify shock early and manage shock as early as possible. Aggressive titration of the inotropes. Don't give more inotropes once the patient maintains pressure on MCS. Identify RV dysfunction early and support it. Identify inadequate LV support and support it. And systemic use of right heart failure. Right heart catheter is mandatory to identify is it LV dominant, RV dominant, biventricular dominant dysfunction. Based upon choose the device. Suppose if you are indiscriminately you are giving IABP, if the patient has advanced shock, it won't improve. Definitely mortality rate is very high. So choose the right device for the right patient at right time. That makes a nice strategy. So every hour in shock associated with 1% increase in mortality, over 50% of the patients BC, if you don't treat aggressively, they may progress to D and E. And patients worsen stage 24 hours had the highest. In the first 24 hours, if the worsening is there, highest mortality. So that is a crucial time you have to reverse the shocks to get the maximum benefit. Always repeatedly you monitor the patient, escalate, de-escalate according to the patient indices. That is very important. So IABP removed on 4th day and patient was discharged on 9th day. If you see the protected PCA, this is a BCS very famous study. This study also did not show any survival benefit with IABP in protected PCA patients. So, but patients who are not on IABP, they worsened with complication. They switched on to the IABP in 13% of patients. But surprisingly, in the follow-up group, they 30% survival benefit. The BCIS during 30 days it may not. But follow-up time patient developed 33% reduction. But exact reason we are not sure. So elective patients, protected PCA, IABP, if we have a mild dysfunction or LVF or reduced or multivessel complex disease or impeller reduced EF, this is the first line of treatment. But if the patient is having a hypoxemia or biventricular dysfunction, better to go with ECMO support. Or if there is cardiac arrest is there, no other choice. First choice is definitely ECMO. This patient actually, if you see, a patient was admitted with a diabetic foot. He was in medicine department and the patient developed pulmonary edema, everything. Then they called me. Then immediately we did the IVL guided stenting of the LAD as well as the LCX, and see the patient recovered very well. But 2 days later, patient developed, 3 days later, refractory VTPF, ventricular storm. So ventricular storm, almost 1 hour. I was talking, the first time in my life, one of my associate was monitoring, 25 times he called me. We were monitoring on phone, DC shock, Xylocard, Maxhelp, everything. Then overdrive pacing was done. He was put on ECMO, and the patient was put on beta blocker therapy, overdrive pacing, and ECMO on that night. Then gradually ventricular storm subsided, and then you see these are you don't give up. Always in such cases, ECMO is the best choice. Put him on ECMO and overdrive pacing, and subsequently we did sympathetic ganglion blockade, mainly to avoid the episodes of VTVF. And you see the patient fully recovered. So always we maintain this is a stellar ganglion blockade. Tracheostomy was done. He was in the hospital for almost 65 days. Now 65 days, you can see where this patient also developed classically why IABP is important in ECMO. Patient developed North-South syndrome and 24 hours unresponsive, hypoxemia, not responding at all. Then we put him on IABP, ECMO plus IABP, over 48 periods. Even a neurophysician came and brain dead. They did MRI, they did EEG, but surprisingly, the next day patient started responding. Then on 65th day, patient went home absolutely without any complications. Even today he is doing very well. So this is the follow-up, 1 month later follow-up. Now, you must know how to use the IABP. That's very important. And to conclude, most important thing is, you must, when you are using the IABP, balloon size is very important. And are you that is inflation, deflation is appropriate or not, connections are proper or not, augmentation is proper or not, all these things you have to monitor, otherwise you may not get a very good results. Thank you one and all for paying the attention.
Thank you, Dr.